This PCORI grant, as you know, grants how do I flip slides? Let's do this. As you know, these grants kind of take over your life. You get started and then you dive in and maybe you start to come up for air after a couple of years. So for this grant, I'm in the dove in, sunk deep, and I'm just at the beginning of starting to come up for air. And so don't have all the results to share with you, but do have some. And for those of you who know me, you know that I'm very interested in thinking about populations and how we can improve care for populations. And so this grant really represents not only one of my favorite populations, which is older adults, but also this concept of what are there strategies that we can use to do a better job taking care of populations by figuring out ways that we can target interventions to them. This is funded by a PCORI grant, and they don't want to take any responsibility for anything I say. So who are we talking about here? This is a typical patient who might enroll in case management, 72-year-old woman, type 2 diabetes, on insulin, has heart failure, hypertension, kidney disease, depression. She frequently gains 20 pounds with edema in her legs, 12 medications, sees 4 specialists, and been in the hospital 5 times in the last year for acute heart failure. So patients that we know. What's the challenge with taking care of this person? So not only do they have high cost to the healthcare system, they have multiple chronic conditions that have to be managed coherently, but oftentimes their care is fragmented, and sometimes that can lead to multiple admissions and readmissions. Case management is intended to help solve some of those gaps. So case management is typically defined as a supplemental service. It's usually a nurse or a social worker or both, and they are responsible for coordinating and implementing care. They tend to work with the patient either alone or in pairs or with an entire team of health professionals. So it might be a number of specialists who come in to help support the case management activities. And they usually do planning and assessment. They coordinate services, so making sure people are getting to appointments and making sure those appointments are being scheduled. They can do patient education. They can also do clinical monitoring. So it's a broad range of skills. One of the things that's not noted here is that often they do this using something similar to a motivational interviewing technique with goal setting and helping empower patients and to really reach their own goals. So at least in Medicare, this is a really important issue, and it certainly is for other populations as well, not just older populations. So 5% of Medicare beneficiaries account for about 40% of total Medicare spending. And case management programs were really developed to help address this. The challenge is that these are very expensive programs. So you think about hiring nurses, hiring social workers, getting them either on the phone, going to visits with people. They're expensive, so they're resource intensive, they're time intensive, and these programs are very, very different. If you can imagine all the different, for a program that covers all the things that we described, you've seen one, right? That's a real challenge with case management programs. And there's very little evidence of effectiveness overall, even though these are just sweeping the country, particularly now with the change in financial incentives for the Medicare population and even some of the younger populations. So the number of case management programs is ramping up. The number of population health programs in general is really ramping up, even though there's not much evidence of effectiveness. We work with how many people have heard of PCORNet? So PCORNet, how many people have heard of PCORI? Okay, so PCORI was that new funding agency that was, it's a public-private funder that was created with the Affordable, that's how you get out of the light. It was created under the Affordable Care Act, and it was very focused on bringing the patient in and kind of reframing reframing the way we think about doing research, so that engaged research, meaning that patients were engaged in the research, other stakeholders like health system leaders were engaged in the research. They really helped develop the questions, and they helped understand what was going on. So intending to create a different kind of research, for any of you who are ever going to be writing grants again, they have had an enormous impact. They have changed the culture. NIH grants, doesn't matter what funder you submit to now, they're going to be asking you, where are your patients engaged in helping you with this project, or where are your stakeholders in this project? So they really changed the way we think about research in this country. They brought, PCORNet is their, what they call clinical data research networks, where they get 10 or 12 academic health systems, and they all come together in a network, and they've got 10 or maybe 20 of these around the country. So I think they've got 200 health systems involved in it. They all take their electronic health record data, they put it in a common data model, and make that available to researchers. We were part of PCORNet here. They brought together all the health system CEOs and said, what do you really want to know? And they said, among other things, they need to improve identification and management of high healthcare utilizers. So this is, again, health systems are saying we need to understand how to identify people for case management and then how to manage those patients. So that then led to PCORI putting out these limited announcements for limited health system demonstration projects. So that was the project that we got here, which was a health system demonstration project. So the project itself is a collaboration. So I'm a PI at University of Wisconsin. We partnered with UW Health. Our other partners were Mass General and Harvard, with their health system, Partners Healthcare, as well as the University of Iowa and University of Iowa Healthcare. And so those, a clicker, that'd be great. So that has been a great experience, and you'll notice that within each of the health systems, we had to bring in health system leaders. So the co-PI of the project was Jonathan Jaffrey, who's the CEO of the UW Health ACO, as well as Peter Weil, who was in the primary care for population health management at Partners Healthcare System, and we had patients across the board. So it's a very interesting team to have health system leaders and patients on your research team. And we have to report to PCORI every couple of months on how that's going. So you have to learn fast how to make that happen and happen right. So the aims of this project were, first, we wanted to characterize case management across health systems in 20 health systems across the country, with the goal being to allow kind of this concept of benchmarking, which the CEOs said they were interested in. They said, we don't even know what other people are doing, right? We have this thing called case management. It's so widely varied. We have no idea what other people are doing. We don't know how to compare ourselves to each other. So can you help us do that? So that was one question, and you can see there the sites. The GPC sites are mostly in the Midwest. That's a Greater Plains Collaborative, and then the Skills, now called Arch, something or other, out of Harvard, and that kind of went down the Eastern Seaboard plus California. Second aim was then to evaluate the effectiveness of case management programs at 3 systems, and so the goal, we had 2 kind of sub-aims with that. The first was to just benchmark patients, and so trying to understand, are people enrolling the same people across all of these different sites, or are they enrolling very different people? The second was then to actually look at the case management programs and see that they were effective. Not having a lot of hope, well, I shouldn't say that. The systems think that their case management programs are great and very effective, irrespective of what the literature says about this. For A1, we started with the PCORNet sites, which were the 20 sites across the 2 different skills networks, skills and GPC networks. We did interviews at 2 sites, that was Partners and UW Health, in order to develop our survey. And then we deployed it, and we did a survey of the 20 sites. We had significant health system engagement and patient engagement, both in helping develop the interviews as well as interpreting the results, and in helping develop the survey and in interpreting the results of the survey. And in fact, I should say that we changed a number of things based on their input. So and that is something that's been my experience once you start to get people at the kind of sharp end really involved in these processes, is that they really help shape what you're asking and how you're asking it to get the best possible information. So maybe we've all done a survey and then gone back, or most of us have gone back and said, and why did we ask that? And we can't understand. We can't even understand what we're asking, much less what the result told us. And so this helps enormously with that. So in terms of the case management programs, we got responses from about 15. It turned out only about 18 were eligible, so the response rate was pretty good. And we ended up with recognizing two different kinds of case management that were going on out there. The first was you had nurses who had relatively small panel sizes, and they had people for relatively short duration, sometimes only a few months, but it was very intense when they were working with them. And they tended to be not on site, so they tended to be centrally located, and then they would, meaning that they were not physically placed in the clinics, they were centrally located in the organization, and then they would work with patients around the health system. The other kind of case management program that was out there, these nurses and social workers tended to have very large panel sizes, sometimes approximating even like a panel size for a primary care physician. They tended to have indefinite duration, like once you were in, you were in, and so then the intensity was very variable. So sometimes there was lots going on, and then sometimes they'd maybe talk to somebody once a year, which makes you wonder, how effective you can be if you're talking to somebody once a year. And they were often integrated on site. They were often placed in the clinics. So those were the two kinds of case management programs that we saw. And by the way, I should say that paper was accepted in Journal of General Internal Medicine, and it will be coming out soon. The second aim was to look at the effectiveness of case management programs across these three systems. Oh, and I forgot to mention the most important piece of this whole project was that the whole thing had to be done in a year. Did I not mention that? So that we'll come back to that, because it got very exciting. When you can see this project. I mean, we're only through aim 1 at this point. And imagine taking a big multi-site project like this, getting up and running and be done in the space of a year. So 3 health systems, we were going to compare patients enrolled in case management, and then we were also going to evaluate the case management program effectiveness. And PCORnet wanted us to do this with their CDRN data, which turned out to have many challenges that I won't go into here. Luckily, we had also said we would use local healthcare claims data at each site. So we were able to complete the project because we had claims data, but we would not have been able to complete it if we had relied only on the PCORnet data. So the methods for the A2 then, we took the electronic health record data at each site from the PCORnet system. We linked it to Medicare claims from the local accountable care organizations. I think all 3 of the sites were in the Medicare Shared Savings Program. And we linked it to their case management registry. Then we had shared resources, so we wrote all the SAS code, the programming code here at Wisconsin, and shared it. And then we wrote it against that common data model. So that was an interesting experience. I'd never done that before, trying to write code centrally and then kind of share it out with different sites. And that was where we really discovered the PCORnet data had major issues. The biggest of which was every single site had a different definition of what they decided a visit was when they loaded the visit table. So the visits the concept of a visit. In some cases, they loaded every single separate procedure code as a visit. In other cases, they, well, we never did figure out what they did. Actually, we never did figure it out. But, you know, they went from having, people went from having, you know, like 100 visits a year to having 0 visits per year in this data. So we gave up on it. We gave up on that part. The other part, the other data, the sociodemographics was okay, but the visit data was terrible. Saved by the CMS claims data. So then for the EHR data, what we did is we matched each case management patient to 2 comparison patients, and we compared the management of patients across the sites. We also then added the local claims data and evaluated the outcome. And the outcome we used was ED visits and inpatient events. In terms of statistical methodology, I won't spend a lot of time on this, but this essentially was a retrospective cohort study design where you have patients with matched comparisons, and we measured outcomes monthly for 12 months before and up to 12 months afterwards for both the cases and comparisons. So we had lots of time points before, lots of time points afterwards for both the groups. And that's a relatively, it's not the same as a randomized trial, but it's a relatively strong design if you have enough pre-information and enough post-information. We also did the matching strategy. We did exact matching, and we did also propensity, exact matching and propensity score matching, and then did propensity score weighting to adjust for any remaining differences. And our statistical, we did longitudinal modeling, then of risk-adjusted differences in outcome strategies with sort of various statistical things in there. Now, if you look at the case management patients, I'm only going to show a little bit of information on this. You can see across the 3 sites, we had about 700 patients in the first site, 140 in the second site, and about 1,000 in the third site. With respect to having 3 or more chronic conditions, almost all of the patients had that. Very few had chronic kidney disease, which I thought was interesting. But you know, once we started learning more about what was going on here, really the severe kidney diseases, they tend to have their own case management programs, and so for the most part, they ended up being excluded here. Lots of patients with COPD or asthma. 2 of the sites, about a quarter of patients had congestive heart failure. The other one had about 40%. And when we started digging in, the history of this site was that it started as case management for cardiology patients. And even though it was now 15 years later, that launch of how they launched the program still showed up in the proportion of patients that they had, which I thought was very interesting, and we never figured out quite why. Although this was one of the sites that started and people were enrolled forever. You know, you never got unenrolled from case management. It was indefinite duration, so maybe they were just still there from 15 years ago. And then some metastatic cancer, but not much. All right, the next thing we did was, kind of to conclude on this slide, some differences between patients. The one difference was basically a predominance of cardiology at one of the sites, but for the most part, I think we would say relatively similar patients across sites. The next thing we did was look at the case management programs, and it showed, imagine going back to your health systems and saying, you know, this is none of your case management programs are working. Well, we're not done yet, so that's we'll figure out how to tackle that issue. But this is essentially after you get good matching and account for all of these differences in cases and comparison patients, you end up not seeing a difference over 12 months of follow-up, at least in terms of event-based prevented, meaning hospitalizations and ED visits, which is one of the primary things that these programs are intended to reduce. And these numbers are basically, the numbers represent the number of events prevented for every 100 patients enrolled in the program. So the top one would be at Site A. There were 180 event days prevented for every 100 patients enrolled in the program, but that was not statistically significant difference. So that's the first thing. But this is consistent with evidence from the literature that says there's not, we don't find any evidence of reduced events from case management. This is a systematic review that was published in 2015. And so these results were not surprising, even though health systems completely believe that these programs are working. And part of it's because they're very expensive. So if you're going to keep paying for them, you have to believe that they're working. So we ended up getting a second year of funding in order to extend this project, and that's what I'm in the middle of right now. So look at the question, could we achieve program effectiveness? Meaning, could we identify if we could find the right patients to enroll? So if we could figure out a way to target the right patients, could we actually target it towards patients for whom the program would be effective? And so we adapted some tools from precision medicine to create a personalized treatment recommendation, which we're calling the benefit score. The rationale for this is that, you know, most systems use something like a risk score. How many people have heard of HCCs? Anybody heard of HCCs? If you haven't at some point in your life, you will, because there's in the UW Health record, there's this group now, Clinnovations, that they're just making, let's just say they're making sure you code all your HCCs because it has a significant impact on Medicare reimbursement. So a lot of people use something like a risk score, but case managers will tell you when you talk to them, they know that not everybody who is high risk benefits from case management. Some people are just too sick, some people don't engage. There's lots of reasons why using just sort of a traditional risk score is not going to get necessarily people into a program who are always going to be, who are always going to benefit. Sometimes they have conditions that we just can't influence with a case manager no matter what we do. So this is really a problem because when you go out to enroll people, you don't know who's likely to benefit and who's not. You can't tell that in advance. So this leads to wasted resources. You've got these very expensive nurses and social workers who are not able to be effectively utilized and not having maximizing their impact. And we don't have tools to separate patients into these two different groups. So this was the challenge that we have been undertaking in the second year of this project. So this is based on this concept of, I'm calling it a benefit scoring system because it actually ends up being a whole bunch of models put together in order to create a final recommendation. For complex case management, the goal of this is to improve the match between case management programs and the patients who are enrolled in them. The strategy is to use machine learning and precision medicine techniques to develop a scoring system that identifies patients who will achieve cost savings if they are enrolled in complex case management. Most of those cost savings come from reducing inpatient events and emergency department visits. There's two concepts for identification. First, who is typically referred to enroll in a program, and then second, who's likely to achieve savings. And so this is a technique that we worked on. I haven't mentioned it yet, but we have a parallel PCORI methodology grant with one of the biostatisticians here, Mengan Yu, who got funded to create some of the underlying statistical methodology for doing this. And the methodology paper is, I think, accepted at this point at Annals of Applied Statistics. So this was a very interesting process to try and figure out how you could score some of this stuff in a way, you know, kind of adapt, because the statisticians are coming from the genomics and all the precision medicine stuff. So how could you adapt some of those tools in order to make it useful for this kind of question? So this is the grant, matching complex patients to treatments, and this he's got this very nice, it's actually award-winning novel method that incorporates artificial intelligence and does a weighting system. And it has some advantages because you can use typical statistical and machine learning tools for this. So even though it's a new method, you can get to it using traditional tools. What goes into the calculations? So the first thing is we had more than 20,000 data points that ended up feeding into these models. I don't know, I had never really done any like massive machine learning before this. And the first thing I'll tell you is that, you know, your servers like lay down on their backs and stick their legs up in the air and kind of wave them around. I mean, it's really intense on your computing infrastructure. But you feed in more than 20,000 data points, and the one thing I can tell you about machine learning is don't ever go back and try and interpret what comes out of this thing. It's just don't. I now know the theory of why you can't, but I can also tell you, having been through it, don't try to do it. The whole purpose of this is to produce an output or a score or a categorization thing, and trying to figure out why any particular thing from these 20,000 pieces of information showed up will just drive you crazy and take you, and it's just uninterpretable. It's uninterpretable. We ended up with about 600 data points that went into the final models, and not everybody who had that data point benefits. It just meant that they were more likely to benefit. And here's some examples of data points. So this is after I told you not to interpret anything, right? But I can't help it. Everybody wants to know what's in it, right? So these are some examples, but you can't say that is exactly the thing that is, because there's no theoretical model behind this thing. But these are some examples of the things, and at least it has some face validity. 5+ chronic conditions, A1Cs increased in the last year, chronic liver disease, anxiety, kidney disease, inpatient stay, frailty, and so forth. DME purchases. So they're things that make sense, right? They at least, if you were going to say who would potentially benefit from a case management program, these at least make sense. Okay, and so then we looked, we ran these scores, split people into the two different groups, people who had high benefit and people who had no or low benefit, and looked to see if that cutting people into those two different groups would make a difference in program effectiveness. And lo and behold, it did. So that you can see among the people who were put into the group with no low benefit, there was no significant relationship between enrolling in case management and the outcome of reducing event days. But among the people who were put into the high benefit group, there were 237 event days prevented by case management for every 100 patients who were enrolled in the program. So that's a lot better than the last one I showed you, right? This says that actually, if you do precise enough targeting, right? This is precision medicine, right? If you do precise enough targeting of patients, that you'll be able to find the patients who are really going to benefit from the treatment that you want to apply to them. Okay, so then the next thing we did is we have been working with the UW Health Accountable Care Organization here. And this is kind of leaving the grant behind and now moving towards our partnership with the Office of Population Health within UW Health. And we looked at the UW Health Medicare ACO population in a scenario where they would have we wouldn't implement this scoring, and estimated the savings from ED and inpatient for people enrolled in case management. And so what we do is we started out with about 30,000 Medicare patients. We constructed a model that identified people who would typically be enrolled in the case management program. That was about 6,000 patients out of that about 30,000. And then there were another 22,000 that were not enrolled. Those tended to be people who were much healthier, right? This is the 65-year-old who's got maybe high blood pressure, but a long way from case management. That's the large majority of those patients. And we looked at what would happen if you enrolled these patients into case management, and of course, you end up not saving any money, right? Because we've shown that the program overall for the patients who are being enrolled is not effective. Our statisticians convinced us not to try and figure out whether they were losing money. So I can't tell you whether they were actually losing money. But I can tell you it's an expensive program, and if you're not saving anything here, if you add in the cost of the program, you're definitely going to be losing money. So the next thing we did then was we implemented the scoring system on this population. So we took these 6,000 patients and we split them out into the people who the predictive model indicated that they would have cost savings from case management, and those that said there would not be any cost savings from case management. And there were about 2,000 patients, so it's about a third of patients who were going to be benefiting, at least with respect to the ED visits, inpatients, cost savings, and so forth. Now, this is the point at which I say, of course, this is only one definition of outcome, one definition of benefit. Doesn't mean these patients weren't benefiting with respect to improved quality of life or other kinds of outcomes. And if we ever got, some of those other outcomes into the electronic health record, then we could incorporate those into these models as well to see if people were benefiting in those outcomes. But having said that, this is the major reason case management programs are being implemented around the country, is to achieve these savings. And if you enrolled just those 2,000 patients in case management, you would save $9 million. So you can imagine what the next step was, which was implementing this at UW Health. So they had care management programs in all the primary care clinics in UW Health that were focused on taking care of mostly blood pressure control and diabetes. Those were the two target areas for the nurses who were out at the clinic. So what they did in the early part of this year, so that did mean each clinic had at least one case manager associated with it. In the early part of this year, they decided to start using the score to reframe that program around delivery of case management. They trained the nurses in case management techniques and basic skills that were being used by our central case management program here. And then rolled out the score to start enrolling patients. And the target is to have 80% of the nurses' caseload a function of the score, and then 20% from referrals, of course, because you're always going to have patients for whom you want to have, for whom a case manager is going to benefit with important outcomes that are not going to be captured by these outcomes. It might be someone who just needs a lot more attention than it's possible to provide in a busy primary care clinic. And then we started delivery of the scores monthly, so we calculate them monthly. It's calculated from using a combination of claims and electronic health record data, and they are loaded into the reporting workbench for the care managers. So this is what it looks like. How many people here have worked with reporting workbench? No. So this is a tool within Epic where it's based on a registry. So you have an underlying registry that gets populated, and then it shows up in this sort of Excel sheet looking kind of thing. And so the case managers in the clinics can go to this list of patients and see what's going on. And so you can see here, they put in what they're calling the HIP priority score. The HIP stands for Health Innovation Program, which got mentioned earlier. I did not know that was what they were going to call it. So as soon as they did it, of course I've been around a long time, so I know a lot of PCPs. So as soon as they put this in, and the case managers started printing these out to going to talk to their PCPs about them, I started getting calls about what is this thing. And we had done some introductory work, but of course it's never the same as then when you see it show up attached to your patient. So that turned out to be very interesting. So I did about 20 presentations to primary care in the space of about 6 weeks in about March or, I guess it was more May and June, and to kind of answer questions on this, and lots of interesting things. about how you would potentially use scores like this, roll them out, what do they mean, and how can you interpret them, and the most important thing being helping everyone understand that things like this do not replace clinical decision making. This is intended to be an adjunct, but ultimately the final decisions always have to be made by the clinical team, because no scoring system, nothing you ever put in an electronic health record or that comes out of the model is ever going to be perfect, right? You're always going to have to account for other pieces of information. So this is considered to be, this is really an adjunct to decision making. The evaluation, we are going to do a follow-up evaluation. I was not able, one of my great disappointments is that I was not able to get this rolled out with a rigorous evaluation design. It just got rolled out with a big bang, which is going to make evaluation complicated because it just got rolled out everywhere all at the same time. And I understand why health systems do that, but I can just, if we got any health system leaders or operational leaders in here, I can just say there is enormous value in just implementing even a simple, more robust evaluation design so that you can come back and then figure out whether or not this thing was working as you intended it to be working. And so I'm just going to put a plug in. Didn't succeed for this. I'm going to have to do cartwheels and jump through, leap buses and buildings and things like that in order to do the evaluation of this thing. But in the long term, if you could figure out how to just make what I like to call sort of lean evaluation designs into how you roll out programs, it's enormously beneficial. And if anybody ever wants to talk about how you do that, I would love to talk about that, because that is something where I think we can be very helpful. So I think that's it. Yeah, that's it. I'll stop and see if anyone has any questions. Yeah.
So that was phenomenal. And I'll say for somebody who was in a stable health center who was trying to figure out whether the case management program was working, this is beautifully done, and it's really exciting to see this. So I can ask you another question, and I won't, but let me just start with two. So one of them is just sort of understanding what the landscape of case management looks like. Because when you started talking about it, I go back to thinking, well, they really started in heart failure, at least sort of in my role, to prevent readmissions, because it was such an extraordinary problem. And then I think they have expanded, and I wonder kind of what the landscape looks like in these settings, and whether you're just talking about programs that manage folks with multiple medical problems or not. And then the second one, which I'm not sure I think your design takes care of this, but I was always worried about settings to kind of identify these high-risk folks and look to see their outcomes that follow with this problem of regression to the mean.
Right.
You're picking people who are at their worst, and then you're going to just get better.
Right. In fact, I just was reading, I was flipping through, how many people use Flipboard here? No? My goodness, it's a great app. It's just like all the news, you just flip through everything. Anyway, I was flipping through Flipboard last night and looking at, so repeat the question. Okay. All right. So the question was, the second question was, what about regression to the mean as a problem? And I was just flipping through the news last night, and I saw something about this wonderful wellness program. It was like a Harvard Business Review article, wonderful wellness program. And I went through and they explained how much they were saving, and they had picked people for the program, and they looked at their costs beforehand, and then they looked at their costs after they were in the program. And that is a classic example of regression to the mean, because you pick people where you don't have, not everybody is high because they're really high. Some people are randomly high, and so they, you follow them over time, they drop down. And if you don't have the rest of the people in the population to come up, to keep the average the same, then of course they're going to get better. look like they're going to get better. So it's just a statistical phenomenon. The answer to that is to have a comparison group and to look at the differences with respect to a comparison group, which we did have. And so the regression to, there are other potential problems, but regression to the mean is less of a problem and should not be your main problem when you have a comparison group. The first question was the extent to which these programs, who are the patients these programs are really targeting at this point, and why, and is it really all around multiple chronic conditions? And I would say the motivating factor behind most of these programs at this point in time is the change in Medicare incentives, the shift to becoming Medicare accountable care organizations, the shift even in the commercial and even Medicaid populations to becoming accountable care organizations, where health systems are beginning to take on risk, financial risk, for some of their patients. And so they are looking to see where can they reduce some of that financial burden, potential financial burden that they will take in terms of risk sharing. And the way that, if you think about how you would target a population, most people are going to start targeting a population then that is having inpatient and emergency department visits, because those are high-cost events. And those tend to be patients who have multiple chronic conditions. Not exclusively. There are other populations who have a lot of healthcare utilization. I know we've got oncologists here, so oncology is an example, where they've really only got one condition. But for the most part, from Medicare's perspective, the bulk of those patients are going to have multiple chronic conditions. Heart failure is something that is that people have known for a long time. We can keep people out of the hospital if we do it right. And so there were a lot of programs, heart failure case management programs that were started. And in fact, we have a heart failure case management program here. It's a specialty program, and it tends to focus only on heart failure. So one of the other differences that you see with case management programs now is they're not focusing just on one condition like that. It's just like the repurposing of the nurses from blood pressure and diabetes. The goal is to actually sort of think about the whole patient and all of the things that are going on with the patient, and then figure out how you can help solve those problems, whether they be social problems, mental health problems, or medical problems, in order to keep those patients out of the hospital. So I think my sense is that case managements have become refocused to that kind of population. Yes?
I guess I'm curious a little bit, is there any reimbursable billing aspect to case management, or is it something that if the hospital sees it as cost saving or effective, that it's a business agreement that they've taken on instead of actually being cost saving?
Yeah. So the financial sort of business planning aspects of case management, can case management be reimbursed, or how does this ultimately get paid for? So Medicare does pay for case management. We have not joined that part of the case management program because it has a very significant restriction. If you offer case management to your Medicare patients, you have to also offer it to all of your other patients. And if your other insurers don't pay, the patients have to pay out of pocket. So that has kept us from actually going after the Medicare reimbursement for case management, which is a per member per month kind of reimbursement. But at some point we've got to get that figured out, particularly here, where our population is so capitated here with the courts population, and it doesn't make sense that we wouldn't be able to go after that funding. But even in spite of that, if you can think about a Medicare accountable care organization, they now are at risk, the Medicare Shared Savings Program, they are at financial risk for that population. And so if they can succeed in reducing the Medicare expenses enough, they can share in some of the savings. Now, you don't share that very much, and nobody's doing this because they think they're going to make money out of it. That's not why people are becoming ACOs. They're becoming ACOs because they think that it's not going away. This is the wave of the future. We better figure out how to get our arms around populations and understand them and understand the finances and start this transition now, because at some point it is going to be here. It's the idea that health systems are somehow suddenly not going to take any risk anymore for their patients is I don't think anybody thinks that's going to happen. So there's still the financial case is not great, I think is what I would say. But again, it's a function of the insurance company. So if you think about something like doing case, I think good examples would be doing case management in obstetrics, right? It would really come down to the extent to which courts and payers like that were interested in either paying for case management, or if we are already taking all that financial risk because we are capitated here. We often don't act like it in how we practice, but we actually, the health system does have a lot of the financial risk, and they do own courts. Then the financial incentives are already potentially in place to be able to support case management programs.
Let's thank Dr. Smith